It's a distinct pleasure to be here today and see all of you here in the audience, particularly those of you that are survivors. And something I'm going to talk about today is how we get more survivors, how we can treat patients better, and really start to understand more about not just the individual disease, but really how we approach treating individual people. And so treating one person at a time rather than the model we've had for so many years where we treat as a population. And with some of the findings that we're identifying, that this may be the secret to at least unlocking some of the mysteries of pancreatic cancer and really starting to make some advances. So as others had mentioned and Libby said, suggested that this is a fact. This is the survival curves for all cancers and all different types of cancers. And you can see pancreas is at the bottom. And it hasn't changed. This is since 1971, but you can even take that further for another 20 years. We've had some improvements in other cancer types, and in some of those circumstances, personalising therapy has helped. In fact, people are often surprised to know that personalised therapy has been around for a long time, particularly in breast cancer. The ultimate personalised therapy has been breast cancer and the use of tamoxifen. What's interesting to know about that is that tamoxifen was sitting on the shelf of a drug company for many years before somebody worked out or thought about using that in breast cancer. And that's the most successful targeted agent. We could detect that in breast cancer because there's a lot more breast cancer, and also a number of patients that have the particular receptor that you target, the estrogen receptor, is around about 50%. So you can detect that in the way we approach things. But one of our challenges, and I'll go through today with pancreatic cancer, is that it's very diverse. It's not just one cancer group, it's a group of multiple different cancers. We hear about it being the fourth leading cause of cancer death and is projected to be the second leading cause of cancer death by 2020 in Western societies. Less than 5% survive to 5 years. The average survival is dismal. Surgery is the only chance of cure. Unfortunately, only a very small proportion of patients can have surgery, because the disease is far too advanced. And where we're really failing is how we're treating the disease with chemotherapy or new targeted agents because of this genetic diversity of the disease. And that it's a multitude of different diseases, not one disease itself. Even though it's largely ineffective across the board, we still see some patients benefit from it. We can't predict which patients are going to benefit for which particular chemotherapy first, and we try the one that's most likely to work. We can't predict who's going to benefit, which individual is going to benefit from what we do. In surgery, even for each 100 patients we operate on, only about 20% actually benefit. We don't know which ones are ahead of time. Similarly with chemotherapy, we almost guess what's going to be the best chemotherapy because we just don't know. Here we see that when we make our clinical decisions, particularly when it comes to surgery, we use a technique which is called, we'll take it out if we can. So that's very scientific. And we use a measure which is a CT scan. Great invention. It gives us a chance to look at the pancreas. This is the cancer here. And we basically look at these blood vessels here, and I'm sure Steve will talk about this in more detail as to whether we can take that cancer out or not. But what we don't understand is what's that cancer's about? What's it behaving like? Has it already spread or has it not already spread? And there's certainly some ways to go where we can advance what we do with surgery, and Steve and others will talk about that. But the key problem is that we can't treat it with drugs. Our chemotherapies don't work, our targeted agents don't work, and it's not just for pancreatic cancer, it's across the board. And so for every drug that comes to the clinic, there's 10 big failures and another 100 small failures. And that's why they're so expensive, because in order to get one drug to market, you have to try to take 10 drugs to get there. And the effects that they're producing are getting smaller and smaller and smaller. If you need 10,000 patients to prove a difference, what effect are you having on the community as a whole, and what does that cost, not just from a financial perspective, but also how much does that cost from a healthcare perspective? And so what's probably really happening in our current approach is if we compare two drugs, this is the old drug called drug A, and this is the blue box is the number of patients that have some sort of response. On the other side, there's drug B, and you randomize them in a randomized control trial, and you compare them, standard scientific practice. Drug A wins out. and so drug B won't replace drug A. People get clever, and okay, why don't we add drug A to drug B? We get a bit better. Okay, we should use drug A with drug B, and so drug A plus drug B plus drug C, you get a lot of toxicity, you get stuck because you can't add any more drugs to it. And then we're stuck. How do we compare things to that? But when you look closer, what's probably actually happening is that this drug is acting on a different group of patients to the other drug. And so you'll see a mix where most of the patients don't respond. Some of the patients respond to both drugs, but many patients will respond to one drug or the other. And so matching the right patient to the right drug, and the story of personalized medicine goes giving the right treatment to the right patient at the right time, at the right cost, and with the right outcome. So what we're starting to understand as we start to delve deeper is that these cancers are very different. We've always personalized medicine. We've also always looked at an individual patient, taken this information out there that generalizes things to the population and see how that applies to our patient. So what's changed? What's changed is our ability to measure and measure differences between people. This is looking under a microscope. This is a technology that is 300 years old, and we still use it today. This is a genome, and I'll tell you more about that as we move forward to explain that. And we can start to look at the complexity of each underlying tumor and see that even though they look the same, they're very different. And it's not surprising they all behave differently and respond to treatments differently. The second rule of clinical trials that we use today is that when we test a new treatment, we don't test it on different diseases. If you come to the doctor, he says, you're sick, okay, here's a pill. You want to find out what's wrong with you, what's the right treatment for you. So we've known this about many other diseases. Similarly, as we start to understand that cancer is a multitude of different diseases, we have to try and match the right treatment to the right patient. And this is not a new revelation. This is something we've known for 1,000 years, and nonetheless we can measure differences in cancers, but yet we still try and group them the same, just because they come from the same organ. We can now measure differences in the genomes of cancers. So we're all made up of genomes. We have genes. They regulate and they do all our usual physiological processes, and cancer is a disease of the genome. And we have changes where there's small changes, one nucleotide, which is one component of your genome. Big changes where big chunks of DNA can bounce out or bounce in or duplicate or flop from one chromosome to another. And then there's other regulation on top of that by changing the way each individual genes function. And now we can start to measure those. And we're doing that as part of an International Cancer Genome Consortium, which was set up, in fact, by Tom Hudson, who's from Toronto. And it's a consortium of 24 countries brought together really to map out the genomes of cancers. And as a comparison of scale, it took us 15 years and $3 billion to sequence one normal genome. Now we can do that. Well, they like to tell us it's only $1,000 to do it, but it's probably more around about $5,000 to do it, and it takes a couple of days. And that's the comparison as to how rapidly the technology is moving. And so part of the consortium's effort is not just to pull these data together and understand it on our own, it's to make all these valuable data available to the overall community, the research community in the world, so that everybody can start studying particular diseases. And our role in Australia was, together with our colleagues here in Toronto, was to map out all the genetic abnormalities, a roadmap of these individual cancers to start to pick similarities and differences as to how we might be able to target the right drug to the right patient. And so what we did in this program was really run almost like a clinical trial where we'd meet patients early, we'd recruit participants, and we track them down during their patient journey. When they had their operation, when they had their Whipple, we took that samples and we threw the book at it with all the sequences to really understand and map out these genomes. And so we used all the technology that was available to us to pull together and understand the maps or the roadmaps of these individual cancer genomes. And this is not a trivial task, and actually doing the sequencing is now the easy bit. It's the amount of data you generate. For example, we moved to Glasgow. if we wanted to ship the data that we wanted to generate it across and we put it on the internet, it would take 18 months to transfer that information. And if something screwed up the day before it finished, we'd have to start all over again. So the best way we transport information now is that we get one of our students, we give them a bag full of hard drives, and we go for a trip. So this is a cancer genome. And so there's a lot of complexity. So many of you are familiar with chromosomes, and this is how we look at things. And many of us geeks just sit here and stare at this sort of stuff day in, day out. So the chromosomes line up around the outside, and you can zoom in and out of this, and it tells us about every little detail of this genome. These are big chunks that move from one place to another. These are small little variations. These are individual genes that have mutations. They're all color-coded, if you can get close enough to see it. And then we try and map out which genes are abnormal. And it's not just a few genes, there's lots and lots. We don't know what's happening by accident or what's a passenger and what's actually driving that cancer. And how we map that together is key to how we start to personalize therapy. And so what we found, and Libby had mentioned, we found 2,000 genes. We don't know which one of those genes are actually key or vital to the cancer. But what we do know is that apart from some genes, and this is a word cloud, and the size of the letters represents how frequently this particular gene is abnormal, and apart from a few genes that we really can't drug therapeutically, there's a lot of diversity. And what this means is that there's a lot of difference between pancreatic cancers. It means it's not just one disease, it's a multitude of different diseases. And it's little wonder that everybody responds differently to a particular treatment. And if you can imagine, if you've got a clinical trial of 100 people and only one individual responds, you're not going to detect that. So you need a trial in order to pick an individual and get a drug that's approved through our current system. You need to maybe do 5,000 or 10,000 patient clinical trials. And that's never going to happen in pancreatic cancer. This is a slightly busy slide, but what I want to convey here is that now we're starting to delve even deeper into the genomes and understanding the very core causes of the genetic abnormalities that we see in different cancer types. And so we can start to understand that particularly environmental risk factors or inherited genes like the BRCA genes, and what they're actually doing to our normal genomes to convert them to a cancer. And this is very exciting because it gives us an opportunity to really start thinking about prevention, early detection. We can see that skin cancers, we see a signature in the DNA of ultraviolet light exposure. We see, as we age, our DNA changes. There's chemical reactions that go on, and we can see a signal where those people that had older cancers, as an older age, there's a particular pattern, and those that are younger patients have another different particular pattern. We see a smoking signature. We can see individual cancers where there's evidence of tobacco exposure really causing those particular biochemical changes that are occurring. And so you can start to delve deeper and think about where are these changes actually coming from, and then potentially intervene even at an earlier stage with prevention. When we start to look at these cancer genomes, once they look individual, it's very hard to really start to relate things, because if you've only got one individual patient, how do you compare that treatment experience to another? We can start to classify things just based on the way the genomes look, and even a surgeon can pick the difference between these ones. That's messy in the middle, this is pretty quiet, and these ones are a little bit in between. And that's how we start to try and group these together, cancer genomes together, for looking for similarities that will help us advance treatment. And so how can we use this information that we're getting from these genomes to really make a difference for patients? How do we change the way we approach the disease? How we approach cancer? And what clues can we get that give us the direction that we want to move forward in the future? We've gone from a situation where this is a pancreatic cancer, there's the pancreas, that's where it is, we can see it. Okay, let's cut it out. If we can't cut it out, we don't know much else about it. We can now image it, we get closer. We get closer and we look at the chromosomes, and then we look at the individual genes. And how do you resolve this complexity into something that's going to be meaningful and useful? We used to classify cancers based on their organ, and we still do, and that's important if you're a surgeon, because you don't want to be operating on a thyroid one day and on the pancreas the next, and on a foot on the other day after, because it just stresses you out too much and you're probably not going to do a good job. But we're starting to see lots of differences in all of these cancers. Apart from a few common cancers, 60% of cancers worldwide are attributed to the less common cancer types. And we're almost starting to think about cancer as a cluster of rare diseases. We can personalize therapy when we have a common cancer and a particular mutation we can get a drug to because we have enough patients that we can do the test. But pancreatic cancer, particularly with its diversity, the number of patients in the population, the number of patients that are suitable for clinical trials and treatments, makes it very hard for us to advance things in the usual model of development. So what we wanted to try and do and say, well, are there any signals we're getting in the study that we did by looking back, taking the individual's genome, looking at that cancer genome, looking at the treatment that they received, and see, if we predict or try and predict based on their genome what the right treatment might be for that right patient. If that patient happened to get that right treatment just by accident, did they respond? And so we were able to do that and start to make comparisons. And when we didn't get that particular treatment, as Libby mentioned, when we grew some of these samples in mice, then we can test them in those particular mice for that individual patient's tumor to see whether our predicted genome responded to the treatment we thought it should. And so we mapped in detail every characteristic of each particular tumor with every test we had, looking for opportunities where we knew a drug might work, or it worked in another cancer, or worked in another disease, not thinking about it as where the organ of origin, but thinking about it, what particular genetic abnormality can we target? And when we look at those, we see that there are already existing drugs out there, some of which have been tested in pancreatic cancer, but not tested in the right way in a personalized approach, that already exist. And we're simply not matching the right drug to the right patient. Some of them, whether you get a bit more of a response or you combine some of these, you can start to detect that a little bit. But we're really moving towards looking for these particular specific abnormalities and tailoring that right drug to that patient. And these are drugs that already exist. So when we looked at our data and wanted to compare this, we were able to look at those patients, and there were 27 patients that received treatment, 10 of those as to whether we thought they got the right treatment. 17, we didn't think they got the right treatment, or we didn't know. And you looked at the differences, and you can already see just from these early little look at these data, you doubled the survival for these patients. This is no intervention, not telling the clinicians what to do just by random chance they happen to get the right drug. But what we did notice, which is particularly reassuring and exciting for us, is that we could start to see what we call exceptional responders. And we have an exceptional responder here in the room. And so we can see patients that happen to receive the right drug by accident when we predicted that they should get that particular drug. Individuals, this is a trace of CA19-9, and many of you would know what CA19-9 is. This individual patient got the right drug. His CA19-9 went straight down to normal, and his disease was completely clear. Again, another example. This is a patient that recurred. There's the tumor there, the recurrence. Received a platinum-based therapy. Complete resolution of disease. And it's a year's passed since then. No evidence of disease at last follow-up. Other drugs, another drug, Abraxane, and Celgene's a sponsor here, so this is their drug. Another individual who got Abraxane, CA19-9 went down to normal. They had a metastasis. The metastasis was there. We can still see it on imaging. We sort of scratched our head and said, well, we should probably cut this out if that's the only thing we can see. And we cut it out, and there was no evidence of cancer there anymore. It had a complete exceptional response. This is another one, even at an end stage, even when they have similar drugs. This is an individual patient who failed on first chemotherapy, failed very rapidly. He was started on a PARP inhibitor drug, complete resolution of disease. And this is almost unheard of in pancreatic cancer. It doesn't happen very often, but the fact that it does happen means that there's an opportunity for us if we match the right drug to the right patient. Just by looking closely at the genome of some of these cancers, you can see how different biology cancers have different patterns. This one in particular is a HER2 amplified cancer, happens in breast cancer. We have a drug for it. The trials we've done, we haven't tested properly. And it's little wonder, because many patients wouldn't have been thought to think that they had pancreatic cancer, because the metastases didn't go to the liver. They went to the lung and went to the brain. So people would think, well, this can't be pancreatic cancer because it doesn't look like pancreatic cancer. But in fact, because the biology is different and you understand it, it does. So what do we think about personalised therapy for pancreatic cancer? We're seeing some emerging signals when we get it right just by accident, and we're able to track that. And sometimes they're dramatic. The clinical trials in the past haven't picked that up. So there's drugs out there that have been tried in pancreatic cancer or haven't been tried in pancreatic cancer that we can revisit, we can go back to. We can take those drugs straight off the shelf and match them to the right patient, and we need to do that. We can look at why particular people had exceptional responses and learn about them. And so when we see the same genetic makeup in the future, then we know what the right drug is to give. And we need to test these in proper clinical trials to convince everybody. So how do we get this into the clinic, apart from just testing things in clinical trials? And so there's a lot of movement around about how we classify cancers differently. We don't classify them based on an organ. We classify them based on their molecular makeup. This is difficult to push forward, because for many, many years we've been used to doing one particular thing as clinicians, as a whole system. But we have to think about how we do this differently, particularly for pancreatic cancer. And in fact, we feel that pancreatic cancer is the way that we can demonstrate that this approach works for all cancers, as an exemplar of how we can move this forward to advance healthcare and improve outcomes. And so rather than just classifying things based on an organ, we can flip it on its side and think about what's the biology, what's the genetic makeup of your cancer, and start to think about whether you've got pancreatic cancer, lung cancer, breast cancer, ovarian cancer. Because you're biologically, the cancer's similar, perhaps that's the right drug to test for you. And so all this information that's been gathered in different cancer types, often being tested in lung cancer or breast cancer or another cancer, or colorectal cancer. If we see the same target in pancreas, we should get hold of that drug. We should test for that particular, what we call an actionable mutation or an actionable phenotype, and start matching the right drugs to the right patients. How do we do that in a society? We're used to doing things in a very linear way, in a serial way. We only do a test if it might make a difference. We're not going to succeed doing that, because if you don't ask the right questions at that right time, you've missed your opportunity. Now we can test all of these actionable mutations in one go. And so we can start to use this, particularly in pancreatic cancer, because what we're doing right at the moment really isn't working. It might work on occasionally, usually through luck or through clever insights like Dr. Gallinger. But we need to change and think about how we do that. Is the community going to do that? Are governments going to do that? They're not doing that very well at the moment. Perhaps patients can start getting together. Maybe we need some sort of social networking between individual patients, cancer patients, that can communicate and talk about these experiences. When you go to buy something from the shop, how do you know what's the right thing to buy? You get onto Google, you get onto somewhere else, you get people's opinions, and you learn and you understand what the best thing is for you. In no other practice or in no other endeavor is there such a war between individuals or clients or consumers and their end product. There's always engagement, there's always interaction, but in the healthcare system globally, it's very dictatorial. There's a big gap between it. And perhaps doing something about that can help us advance things. The way we're thinking about moving this forward is that when we think about a cancer and think, say, for example, pancreatic cancer, if a company wants to say, I just want to test my drug in this group of patients, they have to try and identify those patients with the right genetic makeup. It costs too much. They can't afford it. They don't want to do it. But where we're working towards is mapping out the individual genomes of individual cancers. And there's an effort here in Princess Margaret working on this that Steve Gallinger is involved in as well, really mapping out what's this particular genetic makeup of this individual person's cancer. and then taking that and matching them to the right drug. And then, if you get it right, you can see profound effects, and you look for profound effects. And then as you move forward, you keep building on this. And it might happen in a clinical trial situation, but it can also happen in the future as a self-learning health system. So imagine that, I'll just skip that, that rather than us doing discrete individual clinical trials, there's a knowledge bank of information. So when you go to see a clinician, the clinician makes a decision based on what information he knows, but also based on their experience. What if you took the experience of every clinician, every pancreatic cancer doctor on the planet, put it together, and we were able to query that and say, well, I haven't experienced this before, but I'm going to look on this knowledge bank and I'm going to say, okay, all right, Mrs. Smith, her genome looks very similar to somebody else's genome up there on this knowledge bank. Hasn't been tested in a clinical trial, but there's 50 people that have a similar genome. They all got different drugs, but this individual patient had an exceptional response to this particular drug. So this is the right choice for Mrs. Smith in this circumstance. This sort of rapidly learning, evolving health system. It's a challenge for us to move because we've been practicing medicine in the same way for many, many years. How do we start thinking differently? How do we start to adopt new technology? So we adopt new technology in so many different ways, but we don't use them in healthcare. My son was 12 months old. He couldn't walk. He was just cruising. He was standing up. He got up on the side of my bed, grabbed my iPhone, looked at it, opened it up, and before I knew it, he'd almost purchased a boat on Yahoo. He can do that. I won't do it here because then I'll probably get sacked because that'll be for global roaming. But you can get Siri. You can say, excuse me, how many planes are there overhead? And within 10 seconds, it'll report to you the trajectory, the position, the name of all the flights that are above you, that are above us right at this point in time. Instantaneously pings 300 databases, brings that information back to you. But we don't use any of that in healthcare. We still write stuff down. We've got to code log in on our keyboard. Can you imagine what advances we can make? This is Google Glass. Put your hand up if you heard of Google Glass. Okay. You wear this as a doctor. You go and see a patient. It's the middle of the night. You're running upstairs. Mr. Whatever is unwell. Oh, who the hell is Mr. Whatever? I never heard of him. Where are the notes? Oh, what's going on? Does anybody know this patient? You come in, you see this patient, instant face recognition because of the central hospital system, tells you all about them, so you already know. Or you can ask, say, who is this patient? And it automatically tells you as you're going up the stairs to see the patient. So you know all about them. It's challenging because these technologies can potentially be abused, and whilst you might get away with watching the football with your wife when you're out for dinner, I wouldn't recommend doing that on a first date. So the important thing is that all this is happening, and medicine's being left behind. We can't change it. The governments aren't going to change it, but the people are going to change it. We're not using any of this technology as well as we could. Even if we knew, and we often know about what the best drug is for a patient because I've got the genome in front of me, just the simple logistics of actually getting that information to the treating clinician, getting them to understand that and enacting it is where we get stuck. We can't get tissue samples to us quick enough because you've got to ring up a pathology department, you've got to get through the secretary, these systems can be easily overcome. And so our challenges are not sequencing genomes, trying to predict the right drug. Our challenges are about day-to-day logistics, and they're societal issues, not technological issues. And so what we want to move forward to is global linkages for research and for healthcare. Overcome some of these challenges, these barriers of privacy, etc. Integrate technology, start sharing and more information. So if there was a product, and people are building this product now, that you can insert a chip that monitors all of your health status, day in, day out, every minute of every day, tracks it. You can look at it on your tablet. You can work out what's going on. It's instantaneous. Who would do that? I'd do that. Everybody do that? How many people are afraid of that? A few people, but it's understandable, but it's going to happen anyway. So we need to adopt it. We need to think about predicting how where the challenges might be, and then make it happen. So if we take things about from a more futuristic perspective as to where we're moving just at this point in time, I'd mentioned we want to understand these exceptional responders, and Harold Varmus announced not that long ago that we need to dig into these old clinical trials and look at them. And you know what the biggest block for clinical trials is? Is that the pharmaceutical companies, even though they have them there, they have the information there and the samples there, we can't access them for some reason. It's not their fault. It's our fault because we don't have the systems in order to be able to do that. We're starting to work on sharing this information. We do that through the ICGC, but really using the cloud to pull together and start to analyze large numbers of cancer genomes, start to learn more about different cancer types. I'd mentioned that. And then start to think of new ways where we can start to test these in a way that will convince our regulators to approve these therapeutics, because the old way of clinical trials, large numbers, we just can't do because an individual cancer or a subcancer type, for example, HER2 amplified pancreatic cancer, probably only occurs in 60 patients per year in Canada. So I'll finish on that note. This is my old town, Sydney.